Well, welcome. Tonight we're going to talk about a subspecialty that a lot of people don't think of until something happens, like my sainted mother falls and breaks her wrist, and then you learn about this very special subspecialty. Why don't we start with an introduction?
My name is Jeff Dietz. I am a partner at New England Hand Associates here in Milford.
Okay, now Jeff, explain to me. I mean, we think of knees, hips. You never really think of a hand specialist yet.
Yeah.
I don't know what would be harder to replace but the function of your hands.
Right, yeah, I think that's been a source of some confusion, I think, in the community. What is a hand surgeon? A hand surgeon is typically an orthopedic surgeon or a plastic surgeon. I happen to be an orthopedic surgeon who specializes in upper extremity surgery. I think over the course of the last 10 years, it's changed a lot. It used to be that the traditional hand surgeon was someone who took care of problems that were from the forearm down to the fingertips. And I think that that's changed a lot. And a lot of the more recent training extended that training back up to the shoulder. So most of the upper extremity surgeons today are trained from the shoulder to the fingertip. So our practice specializes from all different types of traumatic injuries, from nerve injuries, from the shoulder down to the fingertip.
So now, you can think of like when my mom fell. Mm-hmm. She broke her wrist.
She did.
Okay, but is that the bulk of the patients you cover, people who break things, or?
No, we see patients from all different types that have all different types of problems. I think a lot of what we see happens to be trauma, like broken wrists, like broken shoulders, like broken elbows. But we see other problems, nerve injuries, nerve compression syndromes like carpal tunnel syndrome, like a pinched nerve in the elbow. We see all different types of arthritic conditions like rheumatoid arthritis, which is an inflammatory type condition, to osteoarthritis, which is more of a wear and tear type condition. And those types of problems can be as simple as conservative treatment with splinting and anti-inflammatory medications, or it can be as complicated as shoulder joint or elbow joint replacement. Other conditions, we treat a lot of infections and other issues, anything really that has to do with the upper extremity.
Now, when people hear arthritis, mm-hmm. Okay, it's all the same, RA, OA, it's old people, but there's a very big difference.
There's a very big difference. The patient populations between the two types of arthritis are very different. The two types of arthritis are rheumatoid arthritis, which is, again, an inflammatory type condition. That's a condition in which the body is attacking itself, and it manifests as issues that involving the joints, whether it's joint inflammation, joint pain, or even joint destruction. The other type of arthritis, which is the more common arthritis, which is what you were speaking to, is more of an age-related wear and tear, and typically that does occur in older populations, but if you have a genetic predisposition, any arthritic condition can occur at any age.
But now when I think of RA, rheumatoid arthritis, mm-hmm. What did I do to bring that on?
You didn't do anything. You have bad genes. That's it. Rheumatoid arthritis tends to run in families. It usually affects younger patients, typically between the ages of 30 and 50. We do have some patients who are older when they're diagnosed, but that's the typical range. And it's much more severe arthritis. That's a form of arthritis that tends to be very debilitating. And
is that like an autoimmune attack?
It is. It's an autoimmune attack, which is similar to, which is an inflammatory type condition. Yeah. So the autoimmune means that your body's own immune system is attacking itself. When your body attacks itself, it's trying to fight something off by creating proteins that help kill off cells that it sees as foreign. Those materials that it's producing end up destroying the articular joint cartilage in whatever joint it's attacking.
So now, if I've got RA of an elbow, mm-hmm. Am I creating antibodies that go in and, is this like an IgG, IgM attack, or?
These are antibodies that are being recognized as foreign, okay? And the reaction is, the body's reaction to get rid of anything that it sees as foreign is sometimes can be detrimental to certain tissues in your body. It's not just joints that are affected in rheumatoid arthritis. We commonly see people with tendon injuries and tendon inflammation that occurs as well.
What can you do? I mean, was it the anti-inflammatory on steroid?
Right.
I mean, what else can you do?
The treatment for rheumatoid arthritis has changed a lot in the last 20 years. The traditional treatment for rheumatoid arthritis, they were using long medications they've used for inflammation forever, like prednisone and even gold, methotrexate. These are some of the medications that they used to use. Times are changing now, and we're using medications called DMARDs, which are disease-modifying anti-rheumatoid drugs. And those have really changed the face of rheumatoid arthritis. They have, rheumatoid arthritis especially used to be hand surgeons could make their living off of treating rheumatoid arthritic patients. But these days, it's very few patients come into my office that are surgical candidates from rheumatoid arthritis because these DMARD medications are so effective at treating their discomfort and their joint problem.
What do they actually do?
They modify the body's immune response, and so they block a certain immune response. So again, the body is identifying proteins that they're seeing as foreign and developing a response to that's detrimental to the joints. This is a medication that blocks that pathway.
So you're not affecting the tissue or the tendon?
No.
You're just kind of like an immunosuppressant, but a specific.
That's exactly what it is. It's an immunosuppressant. In fact, the people that are on those medications, one of the potential side effects are immune complications, susceptibility to infections and other things that can be related to immune suppression.
I mean, that's always, we go through a lot with the organ transplants, and they talk about anti-rejection meds.
Sure.
And I sit there and say, okay, no such animal I know of. I know of immunosuppressants.
Correct.
Where I step on an immune system. Now all of a sudden, I mean, it's like, how many people actually die of AIDS? It's not the AIDS, but all of a sudden the pneumonia or the viruses that just take advantage of an immune system that's stepped on.
Sure.
Now you can't fight them off.
Sure. Yeah.
So do we have the same risk in treating people with immunosuppressants?
To be honest with you, I don't know the comparison from a situation like a disease like AIDS or other immune diseases, but certainly I think the infection rate would be lower with these. Otherwise, they would be a medication that wouldn't be reasonable to give a patient.
Yeah, I mean, you can live with RA, as painful as it sounds.
And they're given in doses that I think modify the immune response, but don't kill it.
Don't kill it. Don't step on it totally.
Sure.
So where does RA, you're talking your world starts here, ends here.
Sure.
Where do you treat most? Is it hands, elbows, shoulders?
With regard to rheumatoid arthritis, I think the majority of the patients that we see that have issues from that disease process are typically the wrist and fingers. The larger joints, obviously the most common joint affected by, the larger joint affected by rheumatoid arthritis would be the knee. And certainly I'm not the person you're going to see for that.
Yeah, I was going to say, that's further away than the shoulder.
Right, so what we see typically are issues with bad joint destruction from rheumatoid arthritis in the fingers and specifically in the wrist joints.
Now, is that because we're playing on the computers too much, or?
No, I don't. The osteoarthritis, rheumatoid arthritis, has never been proven to be linked to any one specific activity. It has been linked to potential post-traumatic issues, so somebody who has a fracture like your mother did, who has involvement of joint surfaces, that can lead to an arthritic type condition, but it's never been proven to be related like other types of overuse types of conditions, to things like typing on the computer or our use of
So the
devices.
threat of telling your kids that they're texting too much and they're
Well, I'm
going
going to use that myself on my children, but that doesn't mean you can't use it, but it's certainly not a lot of evidence
I was
to
going to say,
support
we're being
that,
a
so
bit
to
of
speak.
economical with the truth when we
Well,
try that.
Not specifically arthritis, but there are other conditions, overuse type injuries, that
Carpal
are
tunnel.
just as debilitating that can be related to overuse. Not just the fact that they're very annoying is the reason to curb your use of devices.
Now, we hear a lot about carpal tunnel. Mm-hmm. Where's the tunnel?
The carpal tunnel is made up of a series of bones in your wrist and a ligament that sits over top of the bone. That makes a cylinder or a tunnel that enters your wrist at the base of your thumb. Within that tunnel runs 9 tendons and a nerve. Carpal tunnel is a pinched nerve in your wrist, and that nerve is called the median nerve. It's responsible for sensation to the majority of your hand and some motor function to your thumb. So patients that come in to see me with carpal tunnel typically are complaining of numbness and tingling in their fingers, sometimes a loss of coordinating movements in their hand, they're dropping objects, and the majority of patients seem to have symptoms that are more frequent at night.
But now, we associate that with too much typing or things, again, economical with the truth, or is there some...
So I think that I see a lot of patients that anecdotally will tell me that they never had any symptoms until they started their new job as a data entry person. But there actually has never been any proven literature to support the concept that carpal tunnel syndrome is caused by an overuse injury like typing. I think that people are probably prone to it, and I think there's one specific activity that they're overdoing that can aggravate a condition that they're prone to.
So you don't think it's trauma or anything on that line?
Oh, certainly trauma can be a cause of carpal tunnel. We commonly see that in wrist fractures. That's is something that you would see. Anything that increases the pressure within the carpal tunnel can increase your risk for carpal tunnel syndrome. So it could be traumatic in nature. It could be rheumatoid arthritis. It could be a mass within your carpal tunnel. So the idea that you have carpal tunnel doesn't necessarily imply what the problem was or what caused it.
But now I've got 9 tendons and 1 nerve.
Correct.
All sharing the same space.
That's right.
What do I do to treat that?
The treatment for carpal tunnel can be as simple as, the whole idea is to decrease the swelling and decrease the inflammation within the carpal tunnel, and that can be accomplished by bracing the wrist or splinting the wrist to decrease inflammation, sometimes medications like anti-inflammatory medications, sometimes cortisone shots, and then other times we need to surgically release the carpal tunnel. And all of that depends on your clinical symptoms and the severity of your clinical symptoms, as well as sometimes testing that we use that can tell us how severely the nerve has been affected by the increase in pressure.
Now, to a layman, when I hear a cortisone shot, okay, the body is mounting an inflammatory response because it's telling me it's not happy.
Right.
And it wants to get my attention.
Sure.
So you shoot cortisone in, and I think, okay, I'm masking it. Kind of like have a couple good solid drinks.
Right.
But I really haven't dealt with the issue, have I?
Well, I think that in a situation where you have what's causing carpal tunnel, maybe a mass or a broken bone that potentially is impinging on the nerve,
okay,
you're clearly not taking care of that problem. By carpal tunnel injection is probably not going to be the solution there. But I think the majority of people that have idiopathic carpal tunnel, typically it's related to a temporary increase in inflammation. And you're right, not all the time is an injection effective at decreasing that inflammation. But commonly patients will say that, 1 cortisone injection and my symptoms were gone. What we know from our literature is that carpal tunnel injections are most effective for people who have very early and very mild carpal tunnel. So
I was going to say, is placebo spelt with a capital P?
I think to some degree, I think that there's something to that. People will say.
And I can see I did something to my wrist.
Sure.
Now, while you treat repositioning the bone or while you do something, the cortisone is going to make me feel better.
Uh-huh. It's going to make you feel better. That's right. Yep.
But if you don't treat the root cause, when that cortisone, I mean, eventually the body's going to absorb it.
Right.
Don't I still have that bone squeezing?
Yeah, I mean, I think that in those types of situation, again, where you have an anatomical abnormality that that you're not addressing, it's likely to recur. And in those situations, those people are probably more prone to needing a carpal tunnel release or more aggressive surgery, or more aggressive treatment, I should say.
Now, you mentioned that most people, it's either a plastic surgeon. Where does plastic surgery come in if I've hurt my wrist?
The plastic surgeons
I mean, I've got a wrist. It looks like a wrist. I think of plastic surgery as altering the appearance.
Right. I mean, if you think about what we talked about earlier, a lot of my practice is trauma. And a lot of what the trauma is to the hand is soft tissue. It's not just bone. It's skin loss, and people who have amputations of their finger and they lose portions of their tendons and soft tissues. And some of the people that are best trained to deal with soft tissue complications and problems are plastic surgeons. That's what they do everywhere else in the body, moving skin from one place to the other, covering open wounds, those types of things. So that's where the origin of hand surgery was, in plastic surgery. And that's actually that was one of the rotations that all plastic surgeons will go through during their plastic surgery training, is hand surgery, and that's how it's always been. And I think the way it overlaps with orthopedics, because there's also a lot of bones and joints in the hand. And I think that's why orthopedic surgeons tended to take over a lot more of the conditions that you treat in the hand. So there's a lot of overlap.
Let's see. Let's take a step back. So young Jeffrey Dietz is in college.
Right.
What made you want to be a physician?
I think it was I wanted to be stimulated every day. I think a lot of people have that one experience that either with some medical condition that they had or a family member. I don't think I really had that. I think I just had a desire to be stimulated every day, to do something different every day, to use my hands, and there's the added benefit of hopefully happy patients and people that you've really changed their lives. And that's not a lot of people get to do that every day. I know you get to do that, and that's pretty cool. But not everybody gets to change people's lives every day. I thought that was cool. That's what was the impetus for medicine. As to hand surgery was just a series of paths.
I had had a lot of discussions with college students who are thinking of becoming MDs. And I have to admit, I've said, if you don't have a passion for it, it's a really long road.
It is.
Because, when we grew up, we were joking about it with Frank Saba that there were 3 doctors in Milford.
Sure.
It's Dr. Capisi, Dr. Chiquette. I mean, you can go with Dr. Mastriani.
Sure.
There are 3.
Yeah.
One way or another, everybody went. There was probably 1 or 2 on the outside that we didn't know about.
Yeah.
But everybody you knew had those same 3 primary care physicians. And they made a very good living.
Right.
And felt very good. Mm-hmm. And now comes Obamacare, mm-hmm. or managed health care.
Sure.
Which seems to put a lot of pressure on MDs.
It does. Yeah. I think there is a pressure, especially in a practice that's like our practice. My practice is made up of, there's 3 partners in my practice. We're a private practice, and we have staff that we need to pay. We have a building that we have to keep lights on for. We have supplies that we have to buy. And in order to do that and still make a living, it's getting harder. Reimbursements are dropping. You have to see more patients, which you don't love to do that. You like to be able to see a comfortable amount of patients so that quality care isn't disrupted. But sometimes that's hard because the environment that you practice in, you need to be making sure that you're available.
And I've seen more and more of a trend of young MDs coming out looking at, and we'll get back to the education,
Sure.
but looking at some pretty sizable investments in their education.
Sure.
And then a friend of mine came out and said, okay, I got $200,000-300,000 worth of school loans. Now I have to, if I want to start my own practice, spend another $500,000 or more.
Uh-huh.
So I'm close to $1 million in
That's right.
before I've made a penny. So I don't see as many private practices anymore.
And I think that the day of the small private practice like ours is probably going by the wayside. It's becoming increasingly more difficult to stay independent. The things that you need to negotiate contracts and to stay viable in the community is power. And you don't have a whole lot of power when there's only 3 partners. And so you either have to do one of 2 things. You either have to join another group or just make sure the quality of your care that you're providing is so good that people have to deal with you.
They fight to come to you.
They fight to come to you, and I hope that I think that we're doing that at New England Hand Associates. I think that we have a business model that we work until the work is done, and we don't make people wait at our office, because they're nervous about these conditions. They're worried about their families, they're worried about their work, and we get in to see them. We don't make them wait. We don't have a schedule. We work until we're done.
I can tell you from my sainted mother's point of view. I mean, here's a 90-year-old woman who broke her wrist. So when she walked into your office, there was a lot of tension.
A lot of attention?
No, tension. She was very, very nervous.
Oh, sure. Yeah, absolutely.
And the young lady at the front desk, I mean, big smile. She just made us feel like we were special.
That's good to hear. I like to hear the
you could just
positive
feel
feedback.
Grandma just kind of, one notch down on the tension meter. It's never going to be perfect because my wrist hurts.
Correct.
But it really did feel comfortable.
Right.
And it's a scary thing. You got me walking in with, besides my darling bride and my ungrateful offspring, you turn around and say, there's nobody I'm more vested in than my mother.
Sure.
Right? It's scary when
It
I'm
is.
going to walk into this place. I don't know you,
Uh-huh.
but I'm trusting the health of my mother, or my spouse, my children.
Mm-hmm.
It was kind of nice to feel that homey, hey, this lady cares about us.
I hope so. That's what we try to instill upon our staff, that if people are upset or they're in a bad mood or they, maybe are confrontational, it's only because this is scary to them. This is upsetting to be missing work and to potentially be, if they're self-employed, out a significant amount of money, and those types of things are scary to people, and not to mention the fact that their wrist hurts and they don't know because they haven't seen me yet if they need surgery. Those things are hard, and you can't take anything personal.
Yeah.
You just have to smile and be nice, and I think that hopefully that's what we try to do.
So now you're in college, you decide to be an MD. So you're signing up for at least another 3 to 5 years?
4 years of medical school after undergraduate.
Then 2 years of slavery. I'm sorry. Can't call it slavery anymore, but
Close.
I was going to say 2 years of internship.
1 year of internship and 4 years of orthopedic residency.
4 years. So wait a second. You're ready to retire by the time you can hang out your shingle.
Most of my friends had been working many years before I was done with, quote, school. As my wife's grandfather used to call me, the professional student.
So 4 years of residency.
Uh-huh.
Is that normal for MD, or is it just it's so complicated, a subspecialty, that it takes the time?
I think most of the surgical specialties are typically longer in general, but it depends on what type of medicine you want to practice. The internal medicine doctors, I think, are 3 to 4 years. Pediatrics are 3 years. Neurosurgery is 7 years, I think, so it can be longer. But it's on the long side. Any type of surgical subspecialty, especially one where there's a lot of different procedures to learn and become good and proficient at, it takes a little bit longer to do that. And especially now that rules have changed about the way you can educate a resident, and now residents can't work more than 80 hours a week, and it's harder to do that in 4 years these days. And so, there are people talk
But
about.
still, I know this is blasphemy, but do I want young Jeffrey Dietz to have a sharp scalpel in his hands
Sure.
when he's 70 hours into the week?
Well, yeah, no, I agree. That 80 hours is the maximum. That wasn't what it was like when I was there. And I can't say that I enjoyed all of the times that I had to work 120 hours a week. But I have to say it definitely was educational. And it made me a better surgeon to do that. I learned you can learn a lot more than in 120 hours than you can in 80 hours.
Well, I mean, I could see the argument that says, okay, 4 years, you're going to be able to do X surgeries.
Mm-hmm.
If I cut from 120 to 80, I'm taking a third of the time out.
You're taking a lot of time.
How can you get the same experience?
You can't. That's the short answer is you can't. I think there's people on both sides of this argument, and I think that some people would argue that you may not be getting the experience of that one particular surgery if you've worked for the entire day before that. And there's some truth to that, and certainly safety, patient safety is a primary issue. But you have to worry about, this is a hard thing to learn, and there's so many different aspects of it.
Again, patient safety, if you've gone through, how many surgeries when you left after 4 years did you participated in?
Gosh, I would have to go back and look, but I know it's a lot more than those that finished after me.
I mean, not 10.
No, it's thousands. It's definitely in the thousands.
If you sit there and say, okay, if you went through 2,000, I got to believe that you've gone through more permutations than the guy who went through 1,000.
Oh, sure.
Or the gal who sat through 1,000.
Right.
And, the mark of a surgeon is not how well he or she does when things went perfectly.
Right.
It's when all of a sudden it's like, oops.
And what happens to what you learn in private practice is that your day doesn't end at 6 o'clock like it did for some of the residents. It just doesn't. And, after this, I'm going to go see consultations because that's what happens. People get hurt and I have to go take care of them. And that doesn't stop just because you've reached 40 hours when people need. So when you're in practice, it resembles much more like it was when I was a resident, and less like it does now.
So now, why private practice? I mean, you see the outgrowth of Tri-County, where, a lot of my friends who were MDs, they were very talented, really great with patients. But thank God for their wives to run their office, because they're probably less, how do I put this diplomatically? Their business skills, thank God, were a lot less than their surgical skills.
I think that's definitely true. I think our group is really blessed with three surgeons who have different talents, and I think that they all work together. I think certain private practice groups, you'll have somebody who's very good at business, but everybody else isn't, and that doesn't work. And I think all of us understand the business. My senior partner is really very knowledgeable and understands the business side of medicine, and we're really grateful to have him. And my middle partner, Dr. Brunelli, is a workhorse. The guy is just works his tail off and is an incredible surgeon. And he's really the face of the practice. And so we all have our different strengths, and it really works for us. But the private practice model is, you're right, you have to have the right mix, otherwise the practice will not survive.
Well, I can also see that it's more and more difficult because in non-medical or non-regulated businesses, if you offer a premium service, you're able to charge a premium price.
Right.
Yet I look at CPT codes and I say, okay, it doesn't say a good surgery is, X dollars.
Yes.
It says surgery,
right. X
dollars. So it's got to be harder and harder for you to compete with, people who work at man's greatest hospital.
Right. It's very
Yeah.
harder. I mean, it's very much harder if you look at, the fees that are that you can get when you work for Partners Healthcare. I mean, it speaks to one of the previous points that you make. When you work for a larger institution, you have a lot more bargaining power than you are when you're a 3-man hand surgical group in central Massachusetts. So I think it's a lot harder, but we just are going to keep plugging along and keep providing what we feel is really top quality care. And I think that the rest will kind of take care of itself. I think that bottom line in medicine is if you provide good care and you take good care of your patients and you treat them like they're your own family, like I hope that we do, I think the business is always going to be there.
I don't doubt the business is there. What worries me is when I look at managed healthcare, a lot of my friends who are physicians have said, I could fill my practice to bankruptcy if I took Medicaid patients.
Mm-hmm.
They were telling me that the Medicaid rates cover about 60% or 70% of the true expense.
Uh-huh.
So they have to limit how. It's not that they're being elitist,
Uh-huh.
but they have children like mine who are ungrateful. They want to eat every day and they want clothes every day.
How dare them?
So how dare them? They want to eat every day. So you sit there and say, how do you do that? That's got to be a hard balance to say, I want to help everybody.
I think that when you're part of a community like we feel like we are at Milford, you have an obligation to take care of the whole community. And I don't think that means that you have an obligation to take every insurance that's out there, but I think that if people need care and you're called upon, you have to respond. And I think that's where I think medicine is different, is that in any other business, your business model would be to maximize profits. And there's such a unique aspect of medicine that the product is people, that changes everything. And for us, you try to keep a business mindset, especially when you're in private practice, because you're, like you said, it's money that's coming out of your pocket, but you can't let it, I think,
But you still have to, you have to stay in business. People look and say, you're making hundreds of thousands of dollars and it looks great. Then you say, malpractice is how much?
Right. And I don't want to imply that we don't make decisions that are
well, you have to
business
stay
decisions.
alive.
We do. We certainly do, and we participate in different plans based on what the need of the community is, but also what the best interest of our practice is. And yeah, it sometimes can be tough because you're going
to have those same ungrateful children that want to eat every day.
I have those 3 children, and they are eating me out of house and home. So it's already started.
So now, when you look at the practice, what are the biggest challenges? There you are in a 3-person practice. Now, obviously, you have to live with the same reimbursement rates.
Sure.
But yet, when you buy surgical supplies and all, I mean, if I'm Partners, I'm buying for a few more surgeons than your organization.
Sure.
So I can go in and probably negotiate a little better price.
You're right.
Or a lot better price.
That's a struggle from a financial standpoint. The challenges that our practice goes through, we have obviously our own challenges. I think we're very blessed. The 3, myself, Dr. Jurist, and Dr. Brunelli are good friends. We do very well together from a business standpoint, and I think all have the same view of where the practice should be and how to take care of patients. So that what can be difficult in other practices. The chemistry is good, and that can be difficult in other practices. That can be what ruins a practice. So we don't struggle as much with that.
You mean surgeons with egos? You think that could?
Believe it or not, that happens.
I
know that's surprising to most of your viewers, but that does happen, that surgeons with egos that think that they know the best way to run a practice. I don't think we deal with that as much. And I think that, so that's not something we struggle with, but we struggle with, again, trying to make sure that we can stay independent. And, there's everybody's always trying to eat your lunch. They want what you have. And so trying to carve out your niche and do that is sometimes very difficult.
So now, when you're going to perform surgery, And I really did admire when you told us, here are the options, surgical, non-surgical. And I like making informed decisions. And I felt very comfortable that you were able to walk us through the non-surgical and the surgical, knowing the plus and the minus.
Sure.
If you decide on a surgical treatment, you don't do it at your own place.
No.
Where do you go?
Our group we are affiliated with Metro West Hospital, we're affiliated with Milford Hospital, and we're affiliated with Emerson Hospital. We're not employees of any of the three, but we are affiliated. We try to respect patients' wishes, is the bottom line. So, most of the community here has feels wonderful about Milford Hospital, as do we, and so we try to do those as many as we can at Milford Hospital. But if a patient has a specific request, we try to honor that.
But you have to have privileges. You have to get Milford Hospital, Metro West, to accept your credentials to practice there.
Correct. There's a credentialing process that is pretty similar, but that occurs at every hospital. It's not a universal. So we have to apply for privileges every single year for each of the individual hospitals.
Now, are there differences in what each place charges or what each place requires?
They're very similar. A lot of it is state mandated, what they require of each physician and each surgeon. But there are some specific things to each individual hospital that they want. And yes, there are charges for each of the hospital. I think oftentimes the fees are waived for whatever reason, not at all the hospitals, but sometimes they're waived. But most of the time, I think,
Well, I would think they want
they
surgeons
want you there.
practicing in
That's
there.
how they make money.
Yeah,
We're their customers.
Yeah.
To some degree. Clearly the patients are their primary customers, but if a patient comes to our practice and they want surgery, we
Jeffrey,
ultimately
when
have
I'm in
the
a
choice.
vulnerable condition,
You're going to do
and I'm
go
looking
where.
at you, and you're saying
Yeah.
the best place to go.
Right. Right.
You don't have to say it that way,
Sure.
but I can't imagine I'm going to say, I don't want to go there. I want to go somewhere else.
Right. You have those patients, but you're right. Most people say, where do you want me to go?
Yeah. Where do you?
I'll be there.
I hope I don't know the Milford Hospital
Yeah.
or Metro West as well as you do.
Sure.
Because I'm counting on your expertise.
Sure. Yeah. I think most patients feel that if the doctor's comfortable, they're comfortable. If you're the one that's going to be opening me up and fixing the problem that I have, then I want you to be comfortable. I want you to listen to your music.
So how do you decide which facility to take somebody?
Well, I think that, again, most of it is geographic, I think. Most of the patients that are in this area prefer to stay at Milford. There are some patients that are part of specific or they're the patients of primary care physicians that are part of accredited health organizations, and we try to respect those health organizations and try to help keep costs down by doing those cases at those hospitals. But it varies from case to case. We also have a block time, which means we have a certain amount of time at each hospital that we get to do surgeries on a specific day, and each of us operate on different days, and so that will make the
So you've got Tuesday 8 to noon, and that's your time.
Yes.
You don't have to worry about fighting for an operating room.
No, you have to certainly make sure that you have enough cases to fill that block time, otherwise you don't get block time.
Well, I could see I'd be annoyed if you reserve the room.
Sure.
And there's no revenue coming in.
Right. But our group is, thankfully busy, and we have enough to fill block time most places we go.
Now, is there much of a difference facility-wise? If you go to a hospital, I'm not going to get you in trouble, so I won't ask which hospital, but hospital A versus B.
Sure.
Is it generally the same tools, resources?
I think the instruments are very similar, but I think, there's not enough to be said about the appearance of the hospital to the patient and what the perception of how good the hospital is based on, the appearance of it. And I think that there are some people that feel that doesn't make a difference. We don't need to put money into the hospital and continue to improve. And there are some hospitals that have a different philosophy about that. I happen to think it makes a huge difference. It makes a big difference to my family, where we take our family, and I think that investment is a good one. I think it makes a difference to patients.
Well, I think mentally, again, the big P, the placebo effect.
Oh, yeah, yeah.
When I think about it, we always joke with Frank Saber how when I grew up, it was amazing what a language paradigm that occurred at the little Milford Hospital.
Sure.
Because back then, they allowed 2 visitors, and they actually thought they could control it by giving you a card. So you only had 2 cards. If 2 cards are out, nobody can come in.
Sure.
Well, Milford Hospital was in the Portuguese section. There was always somebody who would open up a back door, and a flood of grandmothers would come in.
Sure.
And the language paradigm was amazing, because people like my mother that have been here since 1940,
Yeah.
when the nurse came in and tried explaining that 12 is greater than 2, all of a sudden, all of them would go, no, speak English.
Yeah. All of a sudden,
All of a sudden,
I don't understand.
I don't
Right.
understand a word.
Right. Well, that's
But
yeah.
the grandma who was in bed, you could see how much more comfortable she was having all of her girlfriends
Sure.
around and being in her hospital in her neighborhood.
Right.
So, I mean, I can see a huge effect.
I think it makes a big difference. I think that the people become very attached to certain hospitals. All of their doctors are at that hospital. They were born there, and somebody gets hurt, and they always go to that ER. That comfort factor can, if you're uncomfortable in a particular environment, it just adds to
Right.
your degree of just feeling that the situation is out of control. And I think
Now, we look at certain things like, you hear about the Da Vinci robot for certain surgeries. Is there anything in the subspecialty that you're in that's, so new and sexy that only the best hospitals can afford?
I would love to say we have a giant laser or a giant robot. I think it's very cool. I think I have watched some of those surgeries, and I think it's very, very neat. But what we do is so small. With respect to the hand, the structures are so small that I think a robot would be, it's probably on the horizon, but I think it would just be too clunky. There is nothing that's out there that is like that. I just don't think that the specialty lends itself to that.
So here, and I'm going to be selfish, being at the center of the
Sure.
universe, the Regional Medical Center here in Milford has all the tools that you as a surgeon need.
And more. They're one of the most accommodating hospitals that we go to. It's really, our practice is very busy, and it's also very trauma-driven, and you can't schedule traumas out. You don't know when they're going to happen, and so you have to have the ability to do those cases when they come in, and that may mean that you have 5 or 6 cases on, and you need to add on the trauma because it has to get done. That's the way we operate. We don't make people wait, and we try to provide good service in Milford, but that requires somebody accommodating what
Sure.
you're asking, and Milford has always been wonderful at accommodating us. Very, 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 very nice place to work.
Well, I mean, you look and you say it would be nice if you could send out a memo. Thou shalt only get hurt Tuesdays
Yeah, I would love
between
that.
3 and 5.
That would be great. That would be great, but that's what I signed up for. So hard to get too upset. It's just, it makes it a lot more difficult when it's, when you have to try to find a place to put that person and there isn't any.
What's the percentage of sports injuries that you run into?
We see a lot. Myself and the Dr. Brunelli do shoulder surgery, and a lot of what you see for shoulder injuries are sports related. So we see a lot of that. Other wrist injuries and finger injuries, there's a lot of those types of injuries that are sports related. I'd say it's a very large part of our practice.
Now, shoulder from, is it baseball pitching? Is it football? Is there anything more prevalent?
A lot of skiing in this part of the.
Never thought about that.
Yeah, a lot of falls and a lot of skiing is what we see. A lot of work-related injury around here. So But yeah, there's sports and all kinds of people get hurt every way. You know, I mean, they're always getting hurt. They can find a way to get hurt on.
I forgot about skiing. Ever
walking out
since
the door.
the other end of your subspecialty, the
Sure.
knees,
Sure.
ever since I tore both ACLs, yeah, skiing and I don't get along very
Yeah,
well.
there you go. That'll make you quit.
Of course, they told me I have to go for surgery because I'm still playing hockey.
Okay.
And, you know, you learn to hate 18-year-olds when you're in an over 18 league.
Yes.
So,
Yes.
you know, you get the advice from the surgeon that says, okay, we can cut part of a tendon and make you an ACL,
Right.
or we can use cadaveric ACLs.
Sure.
So I thought about it. I said, well, that sounds like a better option, but will you kill a young one? Because I got enough old men's
Yeah,
parts.
right.
I want to, if I can get a couple
age
new
of that. I hear you. I hear you.
So the shoulder,
Yep.
if I run through shoulder trauma, I mean, when I broke a wrist, it seemed like kind of a standard 6 weeks.
Mm-hmm.
The body works at its pace.
Mm-hmm.
How much time does it take to bring a shoulder back?
It's certainly a lot longer. I think the larger the joint, the harder it is to recover from that. It certainly depends on what type of injury you have. Fractures are different from soft tissue injuries. The majority of what we do it depends upon the patient population, but a lot of what we do is rotator cuff surgery, and that can be a long recovery, a lot longer than what people think it is. Rotator cuff tears can, there are some people that are still having aches and pains 6-9 months after surgery. They're feeling better, but it can take a lot longer. I think a lot of times these types of injuries and larger surgeries take a lot longer than you think to get better.
Well, it's obviously going to be a lot longer than you want.
I think that's definitely true.
I mean,
a lot longer than you
your
want.
name was very popular with my mother for the last 2 weeks. It's like, how many days and hours till I
Oh,
get this
know.
cast off?
I've been on the other end of that too. My son had a cast on his leg for 8 weeks, and he was counting down the hours before he got off. So I definitely understand.
That's got to be tough because,
Perspective, yeah.
you know, you can hurt yourself.
Yeah.
Okay. But to have your son saying, Dad, this is your job.
Yeah,
Can't you fix me a little quicker?
It's still on. I don't know if you noticed. It's still here. I know, buddy. So you're right. It's very hard when somebody else.
So now when we look at knees, hips, all the, sexiest journal literature is
Yeah.
about new replacement knees and replacement hips. I don't hear a lot about the top end of you.
Yeah, I know. That I think that shoulder replacement, there is some sexy literature out there about shoulder replacement. But you're right. I think a lot of the sexy literature is going to be about the really common problems. And I think that hip and knee arthritis is a very, very common problem. Hip and knee replacement is very, very common. And it's also a very large industry. And so that's why you hear a lot about that. A lot of that is industry driven. The types of prostheses, it may not be surgeon or field driven, it's industry driven.
But your subspecialty, at least to a layman, feels like there's a lot more basic work.
Right. You're right.
There's no magic formula, but we're going to take out the joint. And, Dr. Mulroy's practice will yell at me saying his is not routine. But I see options where you hear, okay, you're going to have your knees replaced, going to have your hips replaced.
Right.
I don't hear about, I'm going to replace parts of your elbow or your shoulder.
Right. You don't hear a lot about that, and the reason is the hips and the knees are weight-bearing joints, and so the arthritis that you see in the hip and knee is much more prevalent because you're putting the full weight of your body on that. You're not putting the full weight of your body across your elbow or your shoulder, so it's much less common.
But yet, when I think about, okay, let's see, I haven't used my knees in this hour very much, but I can't drink my coffee without using my upper body.
It's I think that having an arthritic shoulder is also, just from patients that I know that have had both arthritic shoulders and hips and knees, it's a little bit more tolerable. You can do a lot more with just your elbow and not move your shoulder, and so people tend to accommodate it a little bit more, and so potentially that's why it's less frequent. There are parts of this state that it's very frequent. It's a procedure that's done very, very frequent. Why you don't hear about it here, you're right, it doesn't happen a lot here.
I mean, you got other things like, when you think about breaks or collarbones,
Sure.
okay, what can you do?
For a collarbone fracture? Collarbone fractures, the nice part about collarbone fractures is they tend to heal very nicely. And so the types of fractures that you hear a lot about surgically are typically the ones that either don't heal very well or they don't typically heal in the correct position, so we tend to operate on them. Collarbone fractures are ones that tend to heal very nicely. And so you don't hear a lot about it because we don't operate on it a lot.
But if you do suffer from one, my darling bride forgave me for, quote, breaking the baby when she was playing soccer for me and breaking her collarbone during the game. Yes, I was reminded that I broke the baby for many, many days.
You'll never let that one down.
No. And the fact that she kept playing really got her upset.
Yep.
It happened to be the game that, of course, my darling bride was out of town.
Okay.
And we had no idea, but it was, a tight game, and my daughter broke her collarbone.
Sure.
And then kept screaming at me that she wanted to go back in the game. Yes, my darling bride now, she's very forgiven. She's forgiven me for that every year for the past 15 years.
I don't think I would ever get forgiven for that.
Anything else you want to leave our viewers with?
I think that just that we appreciate this community. We are very invested in this community. And, we hope that we can provide the best care, and we want to let you know that if you do unfortunately have to come to our practice, that we will take good care of you and in a timely fashion. And, we hope that you'll be happy.
The name of the practice?
New England Hand Associates, Dr. Louis Juris, Dr. Michael Brunelli, and myself, Jeffrey Dietz.
Up at the golf course, I can't call it that anymore.
We're not on the golf course. Everybody's going to think we're playing golf all day.
No, but to old people like me,
okay,
that whole area, that's the old golf course.
You could go, all right, fair enough.
It's like I still...
Whatever helps you get there.
Yeah, I still get in trouble with calling Plains Park the dump.
Okay.
But that was the dump. I mean,
right.
to old people like me, that's the old golf course.
Whatever helps you find us is we're okay with.
Well, I certainly hope that people do find you, because if you treat everybody like you treated my mother, we're very happy to have you in Milford.
Thank you for having me.
And as always, we thank the 6 loyal viewers. Hopefully you've learned a little bit about a subspecialty that a lot of us never understood. And as always, may God bless. And let's just hope you never have to go to Dr. Jeffrey's practice. But if you do, from firsthand, you'll be in good hands. Good night, all, and thank you.
Thank you.